Hello everyone, can we start? Hello everyone, hello, good evening. So, is the audio video clear? Can we start? Okay, okay, Dr. Rachna has given us permission. Okay. So, let's start it. Just need to put the class information in other groups too. From the labor expectedly, Dr. Rachna, 2 to 4 questions they come. Today we will be covering half of the labor. Okay, so you can expect 2 questions, right? From the labor topic itself, 4 questions come, right? So we will be covering today half of the topic. So it is considered that we will cover 2 questions in today class. Okay, class will be of 2 hours, so we will be covering one question in every hour. Okay, so let's start it. First of all, we will be starting with induction of labor. Okay, so बच्चा, what is basically induction? Induction क्या होता है? What is induction? Answer? Answer in the chat box. Yeah, it is an important topic, but many of us we don't do this topic, bacha. It is difficult topic. Okay, it is difficult. It is difficult to monitor labor. It is not such that. Okay. Good evening, Jessica. So let's start it. Okay, so it's not a difficult topic. From this topic 4 questions come, and it's not at all difficult. Okay, we will start it. So what is induction of labor? Yes, students, what is induction? And when we do it, come on, be active on the. Yeah, it is. Good evening, Dr. Mohit. It is something like we induce the contractions in the uterus, right? We induce the contraction in the uterus. Sometime already that contractions are there in the uterus, and we have to augment. Either we have to augment it or we have to induce it. Okay, what is different between induction and augmentation? Augmentation means कि there is some level of pains already there. Okay, and we are increasing the labor pains. That is augmentation. Okay, and what is induction? Induction means that there was no pains and we are starting those pains. Okay, do you got the difference between induction and augmentation? Okay, is it clear? Okay, now usually we do it induction at term. Usually we do it at term, that is after 40 weeks. Okay, unless and until. Yeah, very good, Dr. Isra. So induction is usually done at term. Here term means at 40 weeks. Okay, but we start it early if there is any indication Can you give me any indications of preterm induction where we induce the labor before 40 weeks? Can you give me any indication? Please be fast. We have to be fast. We have to cover today all the topics listed. Cardiac. Why cardiac? No, not in cardiac. No. Where we induce the labor early. We are not doing it term. We are doing it less than 37 weeks. We have done all the obstetrics. You must be where we don't wait for 30. Yes, Dr. Jessica, it's right. It is preeclampsia. And it is which preeclampsia? Severe. Right? Severe preeclampsia. What else? Come on, be active. Where we induce the labor early. Yes? Yes, where we induce the labor early. What else? What else? Abruption. It is already written there, beta. In abruption, we induce the labor early. Okay? We don't wait for 37 weeks. What else? Give me one more example. Cholestasis. Right? In cholestasis. Or whenever there is fetal distress. Yesterday we studied now कि we will induce the labor early if there is absent end diastolic flow. If there is reverse end diastolic flow. Isn't it? We studied it yesterday. Absent end diastolic flow and reverse end diastolic flow. We do it at 34 weeks. Right? And here we do it at 32 weeks. Isn't it? We studied yesterday. Very good. Very good. So, in any condition of all these, we induce early. Otherwise, we induce the labor at term. Okay? Very good. Now, you tell me. Attempt this question. Yes, attempt this question. Gravida 2 para 1 is at 35 weeks. Okay. She has no complaint and is appreciating fetal movements well. She had previous cesarean at 25 weeks. Previous classical cesarean at 25 weeks. Now the ultrasound, at ultrasound it is breech. What is the best management? Come on, tell me. Come on, tell me. What is the best management? At present, she is at 35 weeks. She is a case of previous classical cesarean. Classical cesarean was done at 25 weeks. D. Very good, Dr. Jessica. It is, answer is D. D. Okay, why? Very good, Dr. Rachna, Dr. Mohit, very good. So, answer is elective cesarean at 37 weeks. Okay, now we will be studying that what are the contraindication of normal vaginal delivery. The cases in which we cannot do normal vaginal delivery. Okay, in which we cannot do normal vaginal delivery, and they are absolute indication. Bacha, in which we cannot do normal vaginal delivery, we cannot induce labor there also. Okay, the cases in which are contraindication of normal vaginal delivery, it means that they are contraindication of induction of labor also. Okay, are you getting my point? The cases in which we cannot do normal vaginal delivery, we cannot induce labor also. And they are the cases which are absolute indication of cesarean section. Okay, they are the cases in which we do absolute indication of cesarean section. So, anyway the question is asked, whether the question is asked contraindication of normal delivery, whether the question is asked contraindication of induction of labor, whether the question is asked contraindication, indication of cesarean, the list is same. And this is very favorite of FMG. NBE की ये favorite list है. Okay, this is a very favorite list of FMG. They ask one question from the exam. उनकी पूरी इच्छा होती है. Their intention is to ask one question from this list. Now there are 9 points in it. You will listen carefully. If there is category 3 fetal distress, if there is category 3 fetal distress, the most common indication of cesarean is fetal distress. It is the most common indication of fetal distress. Most common indication these days is fetal distress. Okay? Okay. We have to choose answer C. No, beta, answer to that is D itself. Dr. Rachna, answer is D. Is it okay? Is it okay? Okay, Dr. Rachna, we will discuss. We will discuss internal podalic version, but answer is D. Okay? Okay. So we will continue with our list. Okay? So most common causes category 3. Category 3 fetal distress means that it is severe fetal distress. Like we studied previously, which deceleration are severe. Can you tell me which deceleration are indication of severe? Which deceleration? Very good. There are 3 types of deceleration: variable, early and late. Write down in the chat box, when is variable acceleration there? Write down in the chat box, when does variable acceleration come? Very good. Come on everybody. The mnemonic for it was very good. Wheel, chop. Okay. So variable acceleration comes in chord. V for variable, chord compression. Very good. Early deceleration comes in. Come on everybody, write down in the chat box. Early deceleration comes in. Come on. Early, bete, early. Head compression. Very good. And late deceleration comes in. Uteroplacental insufficiency. Very good. Uteroplacental insufficiency. Right? So, only in the late deceleration we have to do cesarean. Right? So, these are something very severe fetal distress. Okay? Is it clear? Okay. The another indication is contracted pelvis. The another indication is contracted pelvis. Okay? The another indication is contracted pelvis. If pelvis is contracted, then we cannot do cesarean. Right? If pelvis is contracted, then we cannot do normal delivery. Okay? Number 3, placenta previa. Okay, central placenta previa. Can we do normal delivery in central placenta previa? If not, then why? Why we do cesarean in central placenta previa? Why we do cesarean in central placenta previa? Yes? Why we do cesarean in central placenta previa? Because patient will bleed a lot. Okay? Yeah, very good. Because first placenta is there downwards, so patient will bleed a lot. Okay, in vasa previa again bleeding will occur, right? And in cord prolapse also, yeah, very good, Dr. Rahul. Cord prolapse also, there will be fetal distress. Name any one indication where in cord prolapse we can do normal delivery. Anyone? In cord prolapse, we can do normal delivery, vaginal delivery or forceps delivery. In which condition? I will write down the question. In cord prolapse, no. In what indication we do forceps or vacuum? Write down. Write down in the chat box. Okay, I will tell you. If cervix is fully dilated, very good, Dr. Isra. If cervix is fully dilated, station is more than +2. Okay, then we can do forceps or normal delivery. Okay, very good, Dr. Rachna. Very good. Otherwise, in every case, we will do the, tell me. Yes, otherwise, in every case, we will do the, good. From this list, definitely question will come. Now, let us talk about surgeries. Okay. How many previous cesarean we do surgery? Dr. Rachna, tell me how much previous LSCS, lower segment cesarean, we should not go for trial of normal delivery. 3. Dr. Isra, it is 3. 3 or more than 3, we are not going to give the trial of normal delivery. Contraindication. Very good. And how much classical cesarean? Yes, how much classical cesarean? Come on, everybody. Come on. 1. Even 1 classical cesarean, we are not going to induce the patient. Very good. Which other surgeries? If the patient has any uterine surgery, for example, uterine rupture, hysterectomy, myomectomy. If the patient had any previous uterine scar, okay? Dr. Issa, what are you asking? Please elaborate. Please elaborate your query. Okay. Beta, there are 2 types of cesarean. See, this is uterus. Okay. There are 2 types of cesarean. This is uterus. If we give the scar in the lower segment, this is lower segment. If we give the scar in the lower segment, if we give the incision here, right, then this is lower segment cesarean section. Write down in the chat box what makes the lower segment. Which organ makes the lower segment? Write down in the chat box. Very important question from anatomy. Very good. Isthmus. Very good. Very good. And if we give this scar in the upper segment, in the vertical scar in the upper segment, that is in the uterus, this is classical cesarean. Okay, lower segment cesarean do not rupture. What is the percentage? Very good, Dr. Rachna Kaushiki. Be specific, it is isthmus. Okay, be specific, Dr. Kaushiki, it is isthmus. Okay, okay. So now you tell me, if lower segment cesarean section undergoes VBAC trial, then what is the percentage of scar rupture? No, Dr. Isra. Scar rupture incidence in LSCS. If LSCS patient goes for vaginal delivery, how much is the percentage of scar rupture? Tell me in the chat box. It is less than 0.1%. Okay, it is less than 0.1%. Is it okay? Okay. Any other uterus scar injury so cannot be given, patient cannot go. If the patient had previous history of uterine rupture, if the patient had hysterectomy, if the patient had myomectomy, no repair. Okay. Now let us study this. In malpresentation, there are some malpresentation we cannot go for cesarean. In transverse lie, can we go for cesarean? Yes. We cannot go for normal delivery. Right? We cannot go for normal vaginal delivery in transverse lie. Always cesarean. Okay, is it clear? Right? Yeah, very good. In which breech delivery we have to go for cesarean? In breech we can go for normal delivery, but there are some breech in which we have to go for cesarean. What are those breech? Write down in the chat box. Write down in the chat box. Yes, star-gazing sign and footling breech. We have to go for cesarean. What is star-gazing? What is star-gazing? See in the camera. When the fetus head is extended like this. When the fetus head is extended like this, it is star-gazing sign. Okay? Clear? Yes, very good. Now, in occipito-posterior, when we have to do cesarean, if the fetus head goes into the deep transverse arrest and the station is less than +2, okay, only, very good. Write down, Dr. Isra, along with DTA, write down +2. Less station less than +2. Okay? Okay. Bete, in Dr. Jessica, Dr. Isra, DTA with station less than +2. Okay? DTA, in DTA, See here, in deep transverse arrest, we can apply forceps, we can apply vacuum, we can do cesarean. But if station is more than +2, yes, very good, Dr. Rahul. In brow, we have always to do cesarean. In brow, no trial of normal delivery. Always cesarean. In face, if the position is mento-posterior, then we will do cesarean. Okay? If the position is mento-anterior, then we will not do cesarean. We will do normal delivery. Okay, is it clear? Is it clear? Okay. Now tell me, infection. Active lesion of herpes. In active lesion of herpes, we will never do cesarean. Okay? Because fetus will get that lesion and fetus can expire because of herpes. So in active lesion of herpes, we never do normal delivery. We have to do cesarean. Okay? Yesterday we did multiple pregnancy. In which twins we do beta cesarean? Write down in the chat box. Yesterday we did. In which twins we do cesarean? Yeah, beta, if baby gets herpes, then baby expires. Okay? Now you tell me, in multiple pregnancy, when we do cesarean? Yes, very good, Dr. Mohit, MCMA. And in MCMA, we have to do cesarean. And in which cases of Dr. Rahul? DCDA we will do. Dr. Mohit, Dr. Rahul, in which cases of DCDA we will do cesarean? DCDA or MCDA? Yes? If the first baby is non-vertex. Yes, if the first baby, write down first baby. Okay? And which is the first baby? Which is lower. Right? These two are not asked, but just to complete the list, I am entering cancer cervix. We cannot do normal delivery. And after VVF repair, vesicovaginal fistula repair, we cannot do normal delivery. Just to complete the list, first 7 wale are always asked. These 7 have been asked many times. Okay? These 7 have been asked many times. Will you help me to complete the list? Number 1 is, what is the most common cause of cesarean? Write down in the chat box. This list is very important. Most common cause of cesarean. Category 3, fetal distress. Very good. Number 2, which is the second most common cause? Contracted pelvis. Number 3, placenta previa. With placenta previa, you will tell me another cause is also vasa previa. Then cord prolapse. Okay. Number 4. What was the number 4 cause? Help me. Number 4. Surgeries. Yes, surgeries. More than or equal to 3 LSCS. 1 classical cesarean. Okay, very good, very good. 1 classical cesarean. Another surgeries. Complete the list with me. Come on, everybody. Complete the surgery list. Previous uterine rupture. Yes, come on. Previous hysterectomy. Previous myomectomy. Very good, very good. You all are very intelligent. Then malpresentation. Complete the list with me. What about the lie? In which lie we do cesarean? Write down. In which breech we do cesarean? In which occipito-posterior we do? Very good. In which breech we do cesarean? Come on, everybody. In which breech? Very good, very good. In which breech we do cesarean? Come on. Very good. Stargazing and footling. Very good. In which occipito-posterior we do cesarean? In which occipito-posterior we do cesarean? Very good, everybody. DTA less than +2. Very good. In which brow? In which brow we do cesarean? All brows. Okay. And in which face presentation we do cesarean? Write down, everybody. In which face presentation we do cesarean? Manto-posterior. Very good. Very good, Dr. Jessica. Very good, Dr. Isra. Very good, Mohit. Very good, Dr. Mohit. Very good, Dr. Rahul. Dr. Rahul, you have gone slower in speed. Which infection is not done cesarean? In which infection cesarean is not done? Yes. Then tell me, in twins. In which twins we don't do? Very good, Dr. Rahul. Okay, you tell me how you will differentiate between primary and secondary herpes. In primary herpes, we do cesarean, whereas secondary herpes is not dangerous. How you will differentiate? Anybody? Simple. We will ask the patient history. Okay? By asking the patient history. By asking the patient history. In which twins we do cesarean? Write down in the chat box. Complete the list. Only some points are left. In which twins we do cesarean? In all MCMA twins. And if it is DCDA or MCDA, then in which twins? Very good, very good, very good. Very good, very good. Okay. If first baby is not vertex, okay. What are the 2 left indications? VVF repair if it has been done. And number 9 is CA cervix. Okay. That completes the list. Very good. Very good, everybody. Very good. CA cervix. Dr. Mohit, it is CA cervix. Okay. 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 Now, what are the methods? What are the drugs by which we induce? What are the medical methods of induction? Whenever we are inducing the labor, we have to, whenever we are inducing the labor, we have to ripen the cervix, right? What are the drugs which we use for ripening the cervix? Come on, everybody. What are the drugs which we use for ripening the cervix? 3 drugs we use: prostaglandins, Dr. Rahul, it should be category 3. It should be category 3. Dr. Rahul has asked if there is no fetal movement in the question, then we immediately do cesarean. Ideally, we should see the category 3 fetal distress. Okay. Ideally, we should do the category 3 fetal distress. Let me take this call. Hello. नहीं start हुआ है. Okay. Okay. Now cervical ripening. Tell me, we have to do the cervical ripening. Okay. We have to do the cervical ripening. Okay. What are the drugs we use? Prostaglandins. We use prostaglandins, mifepristone and oxytocin IV drip. Okay. Oxytocin IV drips. Okay. Now there are mainly 3 type of prostaglandins. There are mainly 3 type of prostaglandins. Prostaglandin E1, prostaglandin E2, prostaglandin F2 alpha. What are the other uses of prostaglandin? Can you write down the 3 uses of prostaglandins? Be fast. We have to complete the half labor today. What are the 3 uses of prostaglandins? Be fast. 3 uses of prostaglandins. What are the 3 uses of prostaglandins? Can you tell me? Prostaglandins are used for abortion. Prostaglandins are used for labor induction. Prostaglandins are used in PPH. Okay, these are in various abortions it is used. Very good. No, Dr. Isra, they are not used in vesicular mole. Delete it. Prostaglandins are not used in vesicular mole. Okay. Prostaglandins are used in abortions. They can be first trimester. It can be second trimester. Prostaglandin are used for labor induction and prostaglandin are used for PPH. Okay. Okay. Now you tell me there are 3 prostaglandins. Prostaglandin E1, prostaglandin E2 and F2 alpha. Okay. What is the name of prostaglandin E1? Mesoprost. What is the name of prostaglandin E1? Mesoprost. This mesoprost, it acts on both. This mesoprost, it acts on both. It acts on uterus and it acts on cervix. Okay, it acts on uterus and it acts on cervix. It acts on both. Whereas prostaglandin E2, it acts only on mesoprost. What is that? Okay, prostaglandin E2. 2. See, here it is written 2. Here it is dinoproston. Dinoproston 2D. 2D. Dinoproston. Though it acts only on cervix. It acts only on cervix. Okay, dinoproston acts only on cervix. Right? And prostaglandin F2 alpha, it acts only on carboprost. It acts only on uterus. Is it okay? Because prostaglandin E1 is acting on mesoprost and prostaglandin E1, very good, is acting on uterus and cervix both. So we can use this for abortion, labor and PPH in all the three. Okay. So prostaglandin E1 is used in abortion, labor and PPH. Okay. Because prostaglandin E2, dinoprost, act only on cervix. So we are not using this dinoprost in PPH. We use dinoprost only for abortion and labor induction. Because in PPH we have to, PPH में हमने क्या करना होता है? Can anybody help me? What do we have to do in PPH? PPH में we have to contract the myometrium. Right? In PPH we have to contract the myometrium. Okay? So we are not going to use dinoproston in PPH. This question is asked and this is considered very easy question. Okay, dinoproston acts only on cervix, so we cannot use dinoproston in PPH. Okay, prostaglandin F2 alpha, which is carboprost, it only acts on uterus, so we can use it in PPH. But we cannot use it for labor induction. Okay? We cannot use it for labor induction. F2 alpha, we will never use F2 alpha for labor induction. Is it okay? Understood? Understood? Now write down in the chat box which prostaglandin is not used for labor induction. Which prostaglandin is not used for labor induction? Write down in the chat box. Which prostaglandin is not used in PPH? Very good, very good. Question number 3, very good. Which prostaglandin is not used for cervical ripening? Write down in the chat box which prostaglandin is not used in cervical ripening. No, Dr. Isra. Answer to question number 2 is dinoprost. Answer to question number 2 is dinoprost. Which prostaglandin? Dr. Dushyant, we are talking about prostaglandins. Which prostaglandins is not used for cervical ripening? Please answer in the chat box. Yes, F2 alpha. Okay, is it clear? Dr. Isra, answer to question number 2 is E2. Okay, now next is, what are the other drugs? Now we know that for cervical ripening, that we have to use prostaglandin E1 and E2 for cervical ripening, right? Prostaglandin only E1 and E2 can be very good used for cervical ripening. What are the other drugs which we can use for cervical ripening? Come on, everybody. Which are the other drugs which we can use for cervical ripening other than prostaglandins? Write down in the chat box, what are the other drugs which we can use for cervical ripening other than prostaglandins? Mifepristone and oxytocin IV drip. Dr. Mohit, please write down IV drip. Okay. What are the side effects of prostaglandins? What is the side effect of misoprost? This dinoprostone is usually drug of choice. Okay, dinoprostone is usually drug of choice. Why? Why dinoprostone is drug of choice? Yeah, why dinoprostone is drug of choice? Why not prostaglandin E1? Why misoprost is not drug of choice? Can anybody tell me? What are the side effects of misoprost? What are the side effects of misoprost? Can you hear me? Misoprost causes hyperstimulation. Misoprost causes hyperstimulation. So, misoprost is contraindicated in heart diseases and VBAC trial. Okay. What are the side effects? Yes, very good, Dr. Jessica. It causes hyperstimulation. So, that is why we have not to give misoprost in heart diseases and VBAC. Very important. Whenever we are inducing heart diseases patient and VBAC trial, we are not going to use misoprost. Okay. The other side effects of prostaglandin E1 is fetal distress and scar rupture. Very good, Dr. Mohit. So, we have not to use misoprost in a patient of heart diseases and in the patient of VBAC trial. Okay. A short note on mechanical methods of induction of labor. What are mechanical methods of induction of labor? Striping of membrane. We just put finger in between the membranes and the cervix. Striping of membrane. ARM, artificial rupture of membrane. And we can also induce labor by Foley's balloon catheter. Okay. We can also induce labor by Foley's balloon catheter. Okay. ARM is contraindicated in. Can anybody tell me where is ARM contraindicated? Anybody tell me artificial rupture of membrane is contraindicated in? Artificial rupture of membrane is contraindicated in. Number 1, heart diseases. Number 2, IUD. Why? Because of the fear of sepsis. Okay. Artificial rupture of membrane is contraindicated in heart diseases and intrauterine death because of the fear of sepsis. Okay. Mesoprost is contraindicated in. Very good. Mesoprost is contraindicated in. Mesoprost is contraindicated in. And ARM is contraindicated in. These two contraindications should be clear to you. Very good. Mesoprost is contraindicated in heart diseases and VBAC because it causes hyperstimulation. Very good, Anshu, Dr. Anshu, very good. Because it causes hyperstimulation. ARM is contraindicated in heart diseases and IUD because of the sepsis. Will you remember it? Will you remember it? Can we go to the second topic? Just give me 1 minute. There is something wrong with the system. Just give me 1 minute. Okay, are you able to see? Are you able to see? Okay, I think it is visible to you. Let us now discuss stages of labor. Okay, stages of labor. How many stages of labor are there? How many stages of labor there are? Come on, everybody. How many stages of labor are there? Come on, everybody. How many stages of labor are there? 4 stages. Okay. So there are 4 stages. What is first stage? What is first stage? Come on, everybody. Let's do it fast. What is first stage? First stage of labor is what is first stage? What is first stage? Dr. Rahul, write proper definition. What is first stage? First stage starts from true labor pains to 10 centimeter dilatation of, yeah, very good. From where the first stage start? This is the point where we get wrong. Yes, Dr. Jessica is right. From true labor pains to 10 centimeter cervix dilatation. Very good, very good. First stage is divided into 2 phases. What are those? First stage is divided into 2 phases. What are those? Be fast. First stage is divided into 2 phases. What are those? Very good, Dr. Mohit. Very good. First stage of the labor is divided into 2 phases. What are those? Latent phase and active phase. Latent phase starts from which phase to which phase? Up till what phase is latent phase? Come on, everybody. Up till what phase is latent phase? Yes, latent phase is up till 5 centimeter and active is from more than 5 to 10. Please keep a note of more than 5. Please keep a note of more than 5 centimeter. Okay? Will you keep it? Remember? Yes, more than 5. Active phase is more than 5 centimeter. I am saying it again and again. Active phase is more than 5 centimeter. Very good. Very good. Very good. Now you tell me that if a patient comes to you, very good. If a patient comes to you in latent phase, what you will do? If a patient comes to you in latent phase, what you will do? If the patient comes to you in latent phase, what you will do? If the patient is coming to you in latent phase, yes, Dr. Isra, full cervix dilatation is 10 centimeter. If the patient is coming to you in the latent phase, what you will do? If the latent phase is prolonged, we have to do nothing. If the latent phase is prolonged, right, we have to differentiate it from that whether it is false labor pains or true labor pains. So, we will give the patient rest and sedation. Okay? Yes, there is some lag in there. If the patient is very good coming to you in latent phase, then you will give the patient rest and sedation. Okay? Rest and sedation. Why we give it rest and sedation? To differential diagnosis it with, so that we can do differential diagnosis from false labor pain. What is the definition of prolonged latent phase? What is the definition of prolonged latent phase? What is the definition of prolonged latent phase? Anyone? Prolonged latent phase, what is the definition? In the primary, what is the definition? And in multi, what is the definition? Please write down. Please write down. It is more than 12 hours for the primary and it is more than 8 hours for multi. Okay? Dr. Isra, please correct yourself. Yes, Dr. Jessica, you are right. Dr. Rachna, you are right. Okay? No, Dr. Rahul, please clear your concept. No, Dr. Rachna, please keep clear. For primary, it is more than 12 hours and for multi, it is more than 8 hours. Will you remember? Yes, will you remember Dr. Rachna, Dr. Rahul, Dr. Isra? Very good, very good. Dr. Rachna, Dr. Rahul, Dr. Isra, please give a thumbs up if you will remember. We are not going to learn any more durations. Only we will learn for latent phase. Very good. 12 and 8. We are only going to learn this definition. 12 and 8. No more definitions. Okay. Now, what is the active phase duration? What is the active phase duration? Can anybody tell me? Active phase. Active phase is. Yes, active phase is. Come on everybody. Active phase is more than 5 centimeter to 10 centimeter. Right? And what is the duration? What is the duration? Normal duration of active phase? 1 centimeter per hour. Very good, Dr. Jessica. It should be 1 centimeter per hour. Okay? It should be very good, very good. The duration is, once the patient is in active phase, patient should dilate 1 centimeter in 1 hour. This is for both multi and primary. Right? This is for both multi and primary. What you will do if the dilatation is not 1 centimeter per hour? What are the reasons? What is the etiology? Tell me. If time is taking more, if dilatation is taking more, tell me. If time is taking more, if dilatation is not more than 1 centimeter per hour, if time taken is more, what is the... Very good, Dr. Isra. Dr. Isra says contractions to be increased. What else? What is the dilatation of active phase, slow progress? Very good, Dr. Jessica. CPD. Very good. Augmentation. One is left. One main reason is left. Anyone can help me? Can anyone help me? One reason is left. Very common reason. Occipito-posterior. Okay? Occipito-posterior. Is it okay? Please take this question. Please take this question. Very good. Answer is C. More than 5 centimeter dilatation with complete effacement. Very good. Very good. Very good. Now let us talk about second stage. Okay. बेटा एक्टिव फेज डॉक्टर रचना इज सेइंग बी एंड सी में कंफ्यूजन है. बेटा व्हाट इज द डेफिनेशन ऑफ एक्टिव फेज? What is the definition of true labor pains? Dr. Rachna, we did it yesterday. True labor pains definition is, tell me, in preterm labor pains we did contractions. What is the definition of preterm labor pain? No, no, you are not taking. No, Dr. Rachna. The definition of preterm labor pains is 4 contractions, more than 4 contractions in 20 minutes or more than Very good, Dr. Isra. More than 8 contractions in 60 minutes. Is the confusion clear? How much was cervix dilatation? What was the cervix dilatation to diagnose the patient preterm labor pain? Very good. How much is the cervix dilatation? More than 3 centimeter. And what about effacement? More than 80%. Is it clear, everybody? Very good. Very good. Very good. Very good. Okay. Now let us study about second stage. Okay. Let us study about second stage. What is second stage of labor? What is second stage of labor? Everybody, please. Yes, very good, Dr. Isa. It is cervical canal less than 20 mm. Yeah. What is second stage of labor? And what is the duration? Second stage of labor starts from fully dilated cervix to baby delivery. Very good. And what is its duration? Dr. Rahul, Dr. Rachna, Dr. Isra, Dr. Jessica, Dr. Mohit. What is its duration? Second ratta. What is its duration? Yes, very good. 2 hours in the primary. One hour in the multi. Very good. Very good. Very good. Very good. Is it okay? Is it okay? What is the duration of latent phase? Is it okay? Very good. Very good. Total duration. Total duration. Total duration. Is it okay now? Will you all remember? Will you all remember? No problem. No problem now. Easy. What is the prolonged second stage causes? What is the prolonged second stage causes? Please write down in the chat box. If the second stage gets prolonged, what is the causes? What are the causes? CPD and decreased bear down efforts. And for both, the management depends on station. Right? Management depends on station. Okay? Very good. Management depends on station. Very good. Very good. And management depends on station. Okay? The management, if station is +2 or more, then we will apply forceps. If okay, okay, thank you. Thank you, Dr. Rahul, for the mnemonic. Yes, if the station is +2 or more, then we have to apply forceps. If the station is less than +2, then we have to apply do cesarean. Is it clear? Is it clear? Write down in the chat box what are the causes of prolonged first stage. What are the causes of prolonged first stage? Yes, CPD, inadequate contractions, and please do not forget occiput posterior. Okay, is it okay? Please do this question, take this question. Yes, very good. Dr. Isra, cesarean is the answer. Caesarean is the answer. Very good, Dr. Rachna, Dr. Mohit. Very good, very good. Now, what is in the third stage? What is in the third stage? In the third stage, there is delivery of placenta. Very good, very good. There is delivery of placenta. And it is 15 minutes for both primary and multi. Okay? Right? And if it is taking more than 30 minutes, it is retained placenta. Is it clear? Is it clear? Very good, very good. Very good. And what is its duration? What is its duration? What is the duration of fourth stage? Basically, in fourth stage, what we observe? In fourth stage, what we observe? Come on, everybody. Very good, very good. In fourth stage, what we observe? In fourth stage, what we observe? Please write down in the chat box. Why we have made fourth stage? For PPH, 1 hour's observation of vitals for PPH. Mainly it is for PPH. Okay? Mainly it is for PPH. Is it okay? Can we go to the next topic? Very good, very good. Now we will be discussing Dr. Mohit, usually staff is checking these vitals. So staff only check BP, heart rate and saturation. You are right. Okay, and per vaginal bleeding. Is it okay, Dr. Mohit? Okay, let's start with maternal pelvis. Okay, now maternal pelvis is basically a cavity. Okay, a cylindrical cavity. Okay, so as in the cylinder we have inlet. Okay, so this is a cylinder. We have the inlet. So this is inlet. Plane of inlet. Plane of inlet. Okay. And this is plane of outlet. This is plane of outlet. Is it clear, everybody? And in between, this is cavity. Is it clear, everybody? Okay. So now, this is our pelvis. Okay. Now, where is our pelvis inlet? From the upper border of symphysis pubis, we will draw. This is inlet. Okay. This is inlet. Okay, I am then disconnecting.